Hello,
Hi.
my name's Tyler. I'm going to be the nurse practitioner taking care of you here today.
Hi.
Can you tell me your first and last name, date of birth?
Rochelle Costarella in 0128-1993.
All right, very good. For this, I'm going to be assessing your cardiovascular and respiratory portion of the assessment. I'm going to look at the chest as well, and we're going to be deferring the breast exam for this part of the video. Any questions that you could think of at the moment?
No.
All right, so I'm going to move to the respiratory part of the assessment. Anytime I start to assess a patient, I'm going to start with the inspection. I'm going to inspect your respiratory status and looking for any signs of dyspnea, any accessory muscle use, any increased like work of breathing, any cyanosis, which I see none. Going to look for your chest, rise and fall, looking at the shape, looking for any barrel chest, lordosis, kyphosis, scoliosis, any skeletal abnormalities that would inhibit the patient's respiratory status. I'm also assessing the patient's anterior and posterior distribution, looking to see that is a 1-to-2 ratio, which it looks to be. Next, I'm looking at inspecting the trachea, making sure it is midline, which it is. Looking at the suprasternal notch and the angle of Louis, which are present. I will also palpate the trachea and make sure it is midline and no deviation. Next, I'm going to palpate the ribs, checking their prominence. Palpate the anterior aspect, the lateral aspect, and the posterior aspect. Any pain where I'm pushing?
Mm-mm.
Good. From there, I'm going to move to palpate for any crepitus, which I don't feel any. The sign of any subcutaneous air, maybe secondary to emphysema. And next, I'm going to move to tactile formatus. I'm going to feel with my palms. I'll have you say 99.
99. 99. 99. 99. 99.
Okay. Next, I'm going to evaluate for symmetric thoracic expansion. Will you turn a little bit for me here if you don't mind? I feel at about the 10th intercostal space. I'm going to have you take a deep breath and exhale. Okay. Thoracic expansion is symmetrical. Next, I'm going to move to percussion. I'm going to percuss anteriorly. Posterior. Laterally. Listening for any resonance, which is what I want to hear. I don't really want to hear any hyperresonance, which would indicate like air trapping, or any dull, percussion that would indicate consolidation or I'm over a solid organ. I'm going to palpate for diaphragmatic excursion. So I'm going to have you breathe normal, and then I want you to exhale completely. Go down to where I no longer hear resonance and I hear dullness. Now I'm going to have you take a deep breath. Keep it. I want you to I'll do that one more time actually. And when I have you take a deep breath, I want you to hold it. Sorry.
Okay.
Mark it there, and it appears to be about 4 centimeters, which is normal. We want it to be about 3 to 5 centimeters. Patients who are well conditioned, like certain athletes, can have it be about 8 centimeters. Next, I'm going to auscultate. Start anteriorly, posterior, and then lateral. Listening for any rales, rhonchi, wheezes, any pleural friction rubs. Deep breath. Okay. Deep breath. Okay. Okay. And then laterally. Okay. Lung sounds are clear bilaterally in all fields. Now we'll go to vocal resonance. I'm going to auscultate. And with this, I'm going to have you say the letter E. I want to hear the letter E through my stethoscope. I don't want to hear the letter A. If I do hear the letter A, that could be a sign of consolidation.
E, 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 E.
I heard E through all fields. Another test we can do is the 99 test or the whisper 1, 2, 3 test. Next, I'm going to move to the cardiac portion. I'm going to inspect the precordium, looking at the apex, the sternal border, and the sternum. For this portion, I'm going to have you lay flat. I'm going to have you turn your head to the left. I'm looking for any shining a light, looking for any jugular vein distension, any pulsation, heaves. I'll palpate the carotid pulse. They're about 2+. Inspecting for any peripheral edema. I can also use the bellow of my stethoscope for auscultate for any bruits. Okay, and now you turn your head straight. Okay. Okay, very good. Now I'm going to actually place that pillow behind your back, and we're going to do this at about 30 degrees. You lay on back. Thank you. Turn your head to the left. And again, I'm looking for any jugular vein distension, any heaves, pulsations, any sign of congestive heart failure. And while we're here laying flat, I would palpate the apex for any pulsation or thrills. Okay, I'm going to have you actually lay on your left side so I can get a better feel. Thank you. Yeah, that's perfect. Okay. And feeling the apex, I do not feel any pulsations. Okay. Now you can sit on up here for me. Next, I'm going to palpate the areas of the precordium, the palm, feeling for any pulsations or thrills over the aortic, which is the second intercostal space, the palmatic, which is at the second intercostal space, Erb's point, third intercostal space, tricuspid, fourth intercostal, and mitral, which is fifth intercostal midclavicular line. Following that, I will auscultate the same areas, listening for a nice even rhythm, S1, S2. I'm looking for any adventitious heart sounds, any S3, S4, any signs of murmurs. For this portion, I'll listen with my diaphragm, aortic, pulmonic, Erb's, tricuspid, and mitral. Then I would listen with the bell, listening for any murmurs present. And I do not hear any murmurs. Hear nice even rhythm. S1, S2, no S3s, no S4s. If I were to hear any murmurs, I would listen for and note the characteristics, the timing, pitch, graded from 1 to 4, and if there were any variation with respirations. The leading up to the end of this exam would be the breast exam. However, we're not going to do that. Any questions, concerns?
No, thank you. That's great.
Thank you.